Hello everybody to this mini battle inlay or onlay patellofemoral replacement. I'm so happy and so honored that I can do this talk for this excellent Patella Lyon happening Congress, and I'm so sorry that I cannot be there in person. But my best regards to David Deschure and the organizational team that do a wonderful job. So I am from Austria, not from Germany, as indicated on the program, just to make that clear. And my part is to fight for the inlay arthroplasty, which is of course the best thing to do. So if you do a mini battle, I think it's about fair play. So we have to strengthen the advantages of your favorite implant, but on the other hand, discredit the opponent's favorite implant. So to do this, we will do that on three battlefields. First, I'm talking about the rationale for the implant, then about the ease of implantation compared to the onlay and outcome evidence compared to onlay. So the rationale of the implant. This is, I think, clearly pro-inlay. This is very easily done. The implant is set into the ambient anatomy and so provides much more natural biomechanics compared to onlay. We are talking about liquid metal that fits into the new shaped trochlea that we produce with our procedure. And what is very important is that it's not possible to produce an overhang of the trochlea, either medial or lateral, and you cannot do any malposition of the trochlea, which is a downside of an onlay implant. And of course, we do a preservation of bone stock. We just take what is needed and not a big chunk of bone in the onlay arthroplasty. It might be very relevant in the young if we preserve this bone stock. So we have a very precise intraoperative topographic mapping. We have 3 patella shapes and we have 8 trochlear shapes. This is very important that we are so flexible to react on different trochlea or patella shapes. Which is clear is the inlay is much more forgiving in implantation, and what is the most important factor, it prevents overstuffing that produces so much stress and problems in onlay arthroplasty. So it's less likely to have a prominent implant at the transition zone, and this is a very important detail in patellofemoral arthroplasty, causing a lot of pain and trouble. Now, how about ease of implantation? So, this is very easy. First, you define your position, which is very easily done with your instruments. You can see that here you have clearly instruments that guide you in the anatomy. You will define your shape and your offset, how deep you want to go, and what is the curvature of your implant. Then you do a very standardized reaming with very easy instruments. Nothing can happen here. Then you just insert this reamer guides. It's fully guided, so there is no problem here. It's very easily done. And then you end up with your trochlear shape. Next, also very guided, you will do your taper post. Then this will be combined to your implant, and just you implant it by hammering it down on the post. Always resurface the patella, always. In the beginning we thought we can do this without a patella resurfacing, but this is not the case, so always do patella resurfacing. You have different options, also easy, standardized. Then you do your trial run, and the next part is cementing of the patella, and you can also use it with cement on the trochlear implant if you think that the bone quality is not good enough. And because it's so quick and easy, you have time for a coffee with the scrub nurse at the end of the procedure before you go on to the next case. So in summary, we have a very high intraoperative flexibility with this implant with 3 patellar shapes and 8 trochlear shapes. You put it in as liquid metal. We have a very precise intraoperative topographic mapping, very reproducible, and you can use it either cemented or in young patients uncemented, which is, in my opinion, an advantage. So it's highly reproducible, and we have standard reaming procedures, and it's not bulky, and this is very, very important to me in all these cases. And you can also combine it with partials, with medial or lateral arthroplasty, and you can also not only use a medial but also a lateral arthrotomy. How about outcomes and evidence? Well, we have really good outcomes in knee scores and activity scores in many papers from 2013 to now, with significantly less progression of tibiofemoral OR in inlay compared to onlay patellofemoral arthroplasty. This is a newer study which shows high patient satisfaction with significant improvement in knee function and pain relief after midterm follow-ups in patients with isolated patellofemoral inlay arthroplasty, published in the KSSDA in 2019. This is another newer study, Journal of Arthroplasty, where it is shown that you can also combine your inlay with a medial. This was compared to a total knee arthroplasty, and there you find that we have lower complication rates, shorter length of hospital stay, and clinical and functional results similar to those of TKA, but without osteoarthritis progression in the unresurfaced lateral compartment in the midterm. Of course, we cannot compare it in the registries because in the Australian registry, analysis is not possible. Also, we cannot compare it to the other registries like the New Zealand, German, Swiss, Swedish, Norway, because they do not report on patellofemoral arthroplasty and they do not contain inlay cases. So, in summary about evidence, of course, it's a more modern, newer implant than the old-fashioned onlay. It's less evidence available, of course, but several studies now in good journals report equal or even superior outcome compared to the onlay. So more evidence is on the way, and multi-center RCTs versus onlay, inlay versus onlay are needed and on the way. So there are also some common myths about inlays. So it's always thinking, but you cannot use it in severe trochlear dysplasia. Of course you can. You will always deepen the trochlea and therefore do the job. You cannot address rotational problems of the femur is another issue. Well, yes, that's true, but also on onlays, this is very limited to some 3 degrees. Otherwise, you will have a problem with your cuttings and undercut your anterior femur. So is this 3 degrees really clinically relevant? I think it is not. And the other argument is, okay, there is too little evidence to use it. Well, I think clearly there is enough evidence now to use it. And with this argument, you could never progress with an implant that is more innovative than the old stuff. So, to my opinion, we have enough data and can argue that this inlay has enough evidence now to be used in a clinical routine. So, to my opinion, the winner is clearly the inlay patellofemoral arthroplasty. And so you know what to do. take the inlay implant. So I think I clearly convinced you what is the best patellofemoral arthroplasty, and no matter what Florian Dirisamer, also from Austria, will tell you, inlay is the best. Thank you very much for your attention.